All right, we're going to pick up here for the next 25 minutes or so, and we're going to talk about ultrasound and looking at lung pathology, looking at things like pneumonia, pneumothorax, and consolidation and CHF. And how many of you have an ultrasound machine in your department? So most of you. How many of you have 30 ultrasound machines in your department? All right, so let me just put this in perspective. I work in a county hospital that has 131 beds. That's the ED, has 131 beds, and we have 30 ultrasound machines. We have an ultrasound division with 6 faculty. This type of chapter, which was written by Mike Heller, he's also written a book on ultrasound, is written by the sort of ultrasound enthusiasts. In my department, the kids are doing ultrasound and they're teaching me. Honest to God, I remember I walked in the department one day and the resident had the vaginal probe in this guy's supraclavicular fossa like a sword with a mound of ultrasound jelly. And I looked at this resident, I was like, psst, well, that's not a vagina. He said, yeah, but the linear probe couldn't get over the clavicle, and this guy's anatomy, his carotid takeoff down low is sort of under it, but the vag probe is an angled array, and it was helping me see behind, and you could see here where the flap is in the carotid coming up. I was like, whatever, okay. Or just, as you were. I remember the first time I saw a resident doing an ocular ultrasound, and I walked in, I was like, what the hell are you doing? Anyway, so that's the kind of environment that these types of papers talking about lung exam come from. They come from an enthusiast environment. You have to be someone who's doing it all the time to do this. Having noted that, how many of you do any work at all in the international world? A few of you here. So in the international world and in resource-poor environments, you might not be able to get a chest x-ray. And in fact, the WHO criteria for pneumonia doesn't include chest x-ray because people in rural clinics in Kenya and all over the place like that, they don't have x-ray machines. They do have ultrasounds now because the clinician brings it with them. So ultrasound is becoming, in resource-poor environments, the imaging modality of choice, and stretching it beyond its traditional role is really becoming important in those environments. So there's a couple of reasons why this is worth looking at. And for the rest of you, it's just sort of an idea of what you might be able to look for and see. I think it's pretty easy to do CHF with ultrasound. I think it's pretty easy to do pleural effusions. And I think it's pretty easy to do pneumothorax. But when you start talking about consolidation and aerobronchograms and the rest of the stuff that are in these papers for pneumonia, it gets a little bit trickier. But there is some reasons to hear about this. So we're gonna start there on page 33. And we're going to talk about some of these papers. Throughout this chapter, I'm not going to go into methods on every single one and break every one of these papers down, because if it was a really important issue for you that you were going to be doing tomorrow in your clinical practice, it would be really worth doing that. But this isn't that. This is sort of like an interest chapter to sort of point you towards things you might look for. But let's just get one sort of methodologic issue out there. So with what I just said about pneumonia and the chest x-ray, and that many places don't have a chest x-ray, and that the WHO criteria are clinical, what is the gold standard for pneumonia? Is it what the doctor thought you had at the end and you defervesced and got better with antibiotics? Is it a positive sputum culture that's consistent with your clinical picture? Is it a positive chest x-ray? Is it a positive high-resolution CT? We already know there's lots of disagreement among all of those gold standards if I was to propose one. We know that lots of people that we've been calling bronchitis, if you do a high-resolution CT, they have elements of consolidation in some areas. They have pneumonia. But they're clinically bronchitis. So do I really want to diagnose 25% more pneumonias by getting a high-resolution CT on everyone with a cough and a fever? Hell no. This is this issue that Jerry's been talking about, which is the diagnostic test too good, as we think CTPA is for some patients with PE? So, having noted that, the real issue in all these papers is, what is the gold standard? You can't tell me the sensitivity is 100% if it's not clear what the gold standard is. So a lot of these papers suffer from that limitation right up front. All right, abstract 1, chest x-ray versus ultrasound for pneumonia. Oh, by the way, if you're also not really an ultrasound pro, and you've been using some ultrasound and hearing some talks about ultrasound, you might already be thinking, ultrasound for pneumonia, what the fuck? I mean, isn't air the enemy of ultrasound? I was always told the reason they couldn't see the appendix was there was a fart in the way. What do you mean? Now I'm going to look at an air-filled space? And indeed that's true, but you can see stuff. So here we are. So this is a single expert is the gold standard. Oh, there's a great gold standard. I anoint myself single expert and author and gold standard. William Mallon, professor of emergency medicine and gold standard. So that's pretty challengeable. 144 patients. They had 5 docs who were good at lung ultrasound, and they got a chest x-ray and they had it read by radiology, and they compared them, and ultrasound sensitivity was 95% and chest x-rays was 60%. Wow, it whipped it. Specificity was pretty high, negative predictive value was better. So ultrasound outperformed chest x-ray based on the single expert gold standard with their clinical course and all the rest of the stuff that went in. So lots of bias there. These are, again, these are the enthusiasts saying that you can do it. Abstract 2, evaluation of ultrasound for pneumonia. Another huge study, N equals 49. So they looked at patients who had a positive ultrasound for pneumonia and a positive chest x-ray, and they said if the chest x-ray is negative, what about the ultrasound when it's positive? And then how did they break the tie when there was disagreement between them? They went to the CT. They said, all right, we'll light them up and do a chest CT. And again, they said that ultrasound beat chest x-ray. Ultrasound had a sensitivity of 97% and chest x-ray 75%. So among these enthusiasts, you're going to recurrently hear these numbers. The chest x-ray doesn't have very good sensitivity for pneumonia. You all know it all depends on what kind of chest x-ray, right? You've all seen a PA and lateral, which you thought, geez, I can really see some detail. You've also seen a supine chest x-ray where you're like, this is a blurrogram of the upper half of the body. I can't even tell you what species that animal is. I, in fact, used to bring in a chest x-ray of my dog every once in a while, back when you put x-rays up and put them up and go, what do you see? And they would be like, well, it's a child. I'd be like, you know. I'm like, yeah, it's a child, maybe with a tail. You know, so we've all seen x-rays like that where you can't really tell them apart. But there you go, there's another one. Abstract 3 is another huge series, N equals 81. So these are all these sort of opening papers with small series done by enthusiasts. And if you're in an environment where people are doing this, you know, we got our ultrasound division walk around, they'll be like, you'll have things. And I'll just tell you one clinical story. This is just from 2 weeks ago. We were working, the ultrasound team was on doing some teaching stuff, so I didn't have to do the ultrasounds myself. But we had this guy with a high white count and a fever. We had a chest x-ray that looked like he had a big effusion, but the effusion wasn't layering out great. You know, you like an effusion to sort of do that sort of moon thing, layering out towards the side. And he was clinically pretty ill. And I just said, hey, why don't you ultrasound that guy's thing? He's got some effusion, some crap going on down there. He's pretty sick. Anyway, they were like, oh, no, this is some abscess thing. It's going towards his spine. I was like, oh. So then we CT'd him up. So in that simple story, the ultrasound really changed me from thinking, oh, this is a pleural and based, pneumonia with a pleural effusion and some other stuff, and he's pretty sick too. This is some invasive abscess thing. And so I was about to admit this patient to the MICU, and instead I called the cardiothoracic unit, and they took him to their unit, and he went to the OR the next day for some anaerobic jam eating into the back of, I don't know, it was, there. So the ultrasound did, in fact, in that simple story, change management. But how common is that kind of disease? That's to use that story of a really pretty rare entity. If I asked you, what do you think that story is? That story 1 in 100 pneumonias? You'd say, no, it's not even that common. Is it 1 in 1,000 pneumonias? You'd be like, I don't know, but maybe about that. So to use a clinical scenario like that to say how great this is in an event that happens maybe 1 in 1,000 times, I think would be a bit of a mistake. Although I did feel helped by it clinically that day a couple weeks ago. Anyway, so abstract 3 with the 81 patients, they said the ultrasound was reliable, sensitivity 98%, specificity 95%, better than chest x-ray, which recurrently in these studies has sensitivities in the sort of 60 to 70% range. And I think that's probably true. And I don't think, if I told all of you in here have been using chest x-ray for your entire careers for this, if I told you that chest x-ray has a sensitivity of 60 or 70% for pneumonia, I think you'd be all thinking, yeah, I think that's about right. I believe that. the face validity of that statement sounds about right. Because a lot of times I'm looking at a chest x-ray and there's lots of insecurity. And I love it when the radiologists read the chest x-ray after the person's admitted and they're in the ICU with a temp of 103 and they got intubated. You know, you thought the x-ray looked pretty normal. Now they're reading all kinds of shit in there because they know what happened to them. I call that reading for the plaintiff. I love it when they do that. Abstract 4 in there talks about this idea when the chest x-ray is unavailable. So we're now talking about these remote environments and that it's useful there. The next 3 papers, 5, 6, 7, all go into peds pneumonia. And we all know that in kids, respiratory pathology, you know, more common than cardiac, certainly if you want to talk about arrests, and respiratory pathology generally more important. And their chest x-rays can be a little bit harder because they got that big thymus and they're very dependent on what their respiratory effort is. It's harder to assess flattening out of their diaphragms because they're little chubbernauts with a flattened diaphragm anyway. So there are lots of reasons why the chest x-ray is a little more obscured in small kids than it is in adults who have a much longer, bigger thorax. And then add to that fact, so the chest x-ray is weaker, now you got smaller ribs, a huge liver window, a good spleen window, the kids are thinner on average, so ultrasound's getting better. So if you just looked at the anatomy and asked, is the ultrasound going to do better in the peds environment or the adult environment for these types of things? And the answer is it's going to do better in the peds environment. And that's indeed what these papers find. 5's a British one with 102 patients, 89 pneumonias, and the ultrasound picks up 88 out of 89. And they use specific criteria. This is a little better methods. They had to see evidence of consolidation, B-lines, and pleural fluid. But a lot of pneumonias don't have a pleural effusion. And they said lung ultrasound allows a radiation-free, reliable workup. I'm not that concerned about the radiation from a chest x-ray. You want to talk about chest CT? Well, let's have that conversation. Chest x-ray? Am I really, you know, is that the chest x-ray, is that my big concern? I don't think so. 6 is a paper that says that the ultrasound was really good in kids, but look carefully when you read that paper, they had to have pneumonia with an effusion. And as I said, that's not all pneumonias. So it's a pretty specific group. 18 out of 19 had the effusion. 1 out of 19 patients went to video-assisted thoracoscopy. Oh, that sounds like a typical pneumonia to me. I'm always sending them to have a scope jammed into their chest. 5 out of 19 of these pneumonias went for surgical procedure. So this does not sound like a typical population of pneumonias. 5 out of 19 had a surgical procedure? So this is again, this is like the story I just told you about the guy with the abscess doing the shit in the back. And, you know, if you take those sort of weird patients and ultrasound them, there might be information. But that doesn't really translate to a regular old everyday I got a cough and a fever, is it pneumonia? That's not the same group at all. That's not fair. So that's the opposite of the straw man comparison, right? The straw man is where you have this. This is really about selection bias, and they've chosen a very sick group of unusual pneumonias to say we're going to look at those with ultrasound. 7 is one of the bigger papers. This is one of the better ones as well. It's in JAMA. 200 kids, one of the larger groups. Chest X-ray versus pneumonia for community-acquired pneumonia. No specific things about them having effusions and things like that. It's got the best study design. It's really a ped study. The median age is 3. I hate it when I look at a ped, they call it a ped study, and I look at the median age and it's like 17. Because 17-year-olds aren't kids, right? They always, you know, the pediatricians always like to say kids are not just small adults. I always argue with them. I'm like, what the hell do you think they are? I mean, show me one that grew up into a hippopotamus. Last I checked, they're small adults. I'm almost certain of it. We've done a trial on this planet with 6 billion kids. They all seem to turn into adults. So I'm just waiting I'll even accept one example where they grew into something else. The other way to say it for them is adults are just kids with substance abuse disorders. I sometimes tell them that. And then finally, if you're into that joke, the third joke is kids aren't just small adults, but pediatricians are. Anyway. All right, abstract 7, so we're looking at this thing. This is sort of the better of these papers, chest x-ray versus ultrasound. And the sensitivity of ultrasound was 86%, so this is one of the papers, I think a little better method, so it's also the first one where the sensitivity comes down under 90%. So now the gap between the two is shrinking. And they look specifically for consolidation and air bronchograms. That was the two findings that they had to see on ultrasound. These findings, the air bronchograms, for example, I do a lot of ultrasound. I live in that culture. I have a hard time feeling good about finding air bronchograms with regularity. Let's go to abstract 8. Ultrasound was better than chest x-ray for important conditions in the critical care arena. Now, this is an arena, if you were saying, let's talk about ultrasound for pulmonary conditions in the ICU, I think that's a much more interesting conversation. You got a population of 10 ICU patients, 5 or 6 of them are on vents. You're always worried when someone's getting positive pressure ventilation, did they develop a pneumo? Ultrasound's great for identifying pneumo. It's really very good. It's quite a bit better than the chest x-ray. That's a lot easier thing to do in terms of what you're looking for there is lung sliding in the gaps between the ribs. That's a much easier exam than looking for these air bronchograms. And in the unit, that would be great. The other thing is if this person has big effusions, because a lot of these people have abdominal processes like liver failure, it's great for that. So you can imagine why in an ICU population where you're kind of getting one chest x-ray a day, right? Then you remember when you were intern in the ICU, and if anything happens later in the day and you call for a chest x-ray, it takes like a year. There's some snail pushing the machine back to the unit, leaving a slime trail. You're like, Jesus, we really need to know what's going on right now. This patient's about to get intubated. And no, if you had an ultrasound, you can answer that question right now. So if you want to have that conversation about ultrasound in the ICU, that's not exactly the same conversation as we have about ultrasound in the ED, but this paper talks about it, said it had, chest x-ray had lower sensitivity, longer delays, and not nearly as useful in the clinical sense, and I find that very easy to believe, that in a unit, if you were facile with pulmonary ultrasound, you could identify pneumothoraces rapidly without calling for a chest x-ray that's going to take you would have some way to look at what their fluid status is and some other things that would be good. Abstract 9 is a European paper. Let's just talk about Europe versus the United States with ultrasound for a second, because that's also important when you're looking at these papers and what their source is. So the Europeans in general are way ahead of us. They're about on average a decade ahead of us in ultrasound usage for a whole variety of things. For example, in my hospital, if I call over to radiology and say I'd like an ultrasound of the Achilles tendon, I think this guy has a partial rupture, there'll be a long pause on the other side of the phone. Well, what? And I'll tell them maybe you should get an MRI. I'm saying, well, yeah, I could if you'd approve it, but maybe we should just do an ultrasound real quick. They're like, so MSK ultrasound in Europe, this is how they do all these things. You're looking for a biceps tendon rupture, an Achilles tendon rupture. You want to know whether it's a Baker's cyst. You want to know whether it's a great big knee effusion. You want to know what this soft tissue mass is. You're looking at a big territory of cellulitis. You want to know if there's an abscess under it. This skin, soft tissue, musculoskeletal ultrasound, and it's really quite easy to do. That way easier than lung stuff, if you ask me. And that in Europe, they're way ahead on this. They've been doing it for 10 years. We're a little bit behind on that. But so here's an Italian paper, so I just want to put that in perspective. The Europeans are generally ahead of us. It's evidence-based recommendations for point-of-care lung ultrasound. It's from Bologna, Rome, and Pisa. I think I need to go and review their work in those 3 cities, maybe a little later this afternoon. I'd like to get over there. It sounds like a rough life to me. It sounds very intellectual and stimulating. Good coffee, pizza, sounds perfect. I think that ultrasound looked great in that environment. And it's an expert consensus conference and a lit review, and they did quality of evidence and grade medicine, and then they did the Delphi thing where the ultra experts got together and had an argument about things and tried to reach agreement. And they had 65 statements that they endorsed, but indeed they say that point-of-care ultrasound for pneumothorax really good, for pleural effusions really good, for pneumonia they think it's pretty good, but not as good as those other things, and there are a whole variety of other things. And so abstract 10 sort of goes and then asks you, you know, is this a new skill that you need to, is this like the academics pushing some other thing on you that you're going to have to learn? And I think my answer to that is no. I think right now the answer is no. If you're in one of these enthusiast environments and there's someone who wants to sort of take you by the probe, if you will, instead of take you by the hand, who wants to take you by the probe and advance your skill set on that, because that's really what you need, is someone good to sort of show you what your images are, right? Because you can't look at the loops on these things. You actually need someone there when you're acquiring the images to get better at it. And if you have that, then great, by all means stretch it out. If you're going to be in a third world environment where there's no radiologic support, by all means learn some ultrasound. But is this ready for prime time? For pneumothorax, I think yes. For pleural effusions, I think yes. For consolidation air bronchograms, less. If you want to have the question about B-lines and rockets looking for heart failure, that's easy to do. But pneumonia is trickier. So, in summary on this, no, you don't need to learn this right now. This is sort of more of a little interest, a teaser chapter about what's out there. If you're in one of those environments, you can sort of be in the know and talk to people about it. In general, the lit's not great, the numbers are small, and there's all kinds of gold standard issues. You could poke holes in this pretty easily. In general, these papers are all done by the enthusiasts either in Europe or here, and so their skill set is probably substantially better with ultrasound than yours is, and so you have to keep that in mind. That means that the external validity of these papers is in general low. You can't just pick up a probe and go do this. Sensitivity and specificity among that enthusiast group of ultrasound for a lot of findings in pneumonia is pretty consistently somewhere between 85 and 90%, and it does beat chest x-ray. I don't find that hard to believe. And it's better in kids. So we'll take a break there. I don't think we need to spend a lot more time on breaking that out. I think it's a little bit of a teaser of where you might be going to next with ultrasound. Thanks.